Hello. Hello, good morning. My topic today is on Efgartimod Alfa, which is one of the new drugs which has been approved for myasthenia gravis. So before I begin, I want to tell you a little bit about myasthenia gravis. And we all know it's a chronic autoimmune disease, and it can really impair quality of life, and sometimes it can even be life-threatening. So some of the symptoms involve ocular motility, speech impairment, trouble with swallowing, mobility, and even respiratory function. So going to the pathophysiology behind it, in 85% of the cases, it's due to autoantibodies, and these are IgG. We have identified three types of autoantibodies that are usually involved. And the most common type is the skeletal muscle nicotinic acetylcholine receptor. And then you have the MuSK antibodies, and then you have the LDL receptor related protein 4 as well. However, we need to keep in mind that in 15% of the cases, no antibodies are detected. However, you do see like a classic presentation of myasthenia gravis. And so what these antibodies do is that they block the receptors, and this causes accelerated internalization and degradation of the receptors. And ultimately, it causes damage to the NMJ, that is the neuromuscular junction, which impairs neuromuscular transmission. One more thing is that the IgG1 variant autoantibodies, such as the skeletal muscle nicotinic acetylcholine receptor antibodies and the LDL receptor-related protein 4, also activate the complement system and cause further inflammation. Right. Now, the existing treatments are mainly steroids, immunosuppressants, and for symptomatic relief, it's acetylcholinesterase inhibitors. Now, the problem with these treatments is that they cause generalized immune suppression, and their adverse effects, for example, for steroids, you have obesity, hypertension, and so on. So the newer therapies right now, what they're coming up with is something which is more targeted to just myasthenia gravis, so just the antibody itself. One of that is the C5 complement inhibitors, which inhibits the C5 complement, that is ravulizumab. And what I'm going to be focusing on over here is the Neonatal Fc inhibitors, that is Efgartimod Alfa. Now, what is Neonatal Fc receptor, first of all? It is an MHC class 1-like molecule. And what it does is that it prolongs the half-life of IgG. That is, it binds to IgG and it prevents it from lysosomal degradation. And this increases its half-life, and it allows IgG to circulate for a longer period of time, and it recycles it ultimately. That's what it does. So what Efgartimod is that it is a human IgG1 antibody Fc fragment. So what this does is that it has a higher affinity for Fc receptor compared to IgG. So it binds it before it can bind IgG. And therefore, IgG loses its protection and it undergoes more degradation and decreases its half-life. Right. So this particular drug was approved for generalized myasthenia gravis in the United States in 2021. Now we're coming to the study which led to further studies and ultimately approval, and that is the ADAPT study, ADAPT study. So the design of the study was a randomized, double-blind, placebo-controlled, multi-center phase 3 trial in patients with generalized myasthenia, and it was conducted over 26 weeks in a total of 167 patients. And these patients, they were recruited from 56 centers, neuromuscular centers across Japan, Europe, and Northern America. The inclusion criteria was that they need to be 18 years old, and they could either have positive antibodies or not, but they need to be classified according to the Myasthenia Gravis Foundation of America class 2 to 4. And this score is very important, they had a Myasthenia Gravis activities of daily living score of at least 5. So that is MGADL. It's going to crop up several times throughout the study. Now, one other inclusion criteria was that they needed to be on at least one treatment for generalized myasthenia gravis. It could either be acetylcholinesterase inhibitors, steroids, or any immunosuppressant. And this was before screening and throughout the entire duration of the trial. Now, the exclusion criteria was if they've received anything like rituximab, eculizumab, undergone thymectomy, they've done IVIG or plasmapheresis, they have hepatitis B, Hep C, active HIV, low IgG counts, and if they were pregnant. Now, so patients were assigned 1:1 ratio to either efgartigimod or placebo, and they stratified the population according to the acetylcholine receptor antibody status, if they were taking non-steroidal immunosuppressants or not, and if they were Japanese or no. Now, the procedure itself. So efgartigimod was given in infusion cycles, and it was 10 mg per kg. And so usually per cycle, you have 4 infusions, and that means 1 infusion per week for 4 weeks. And after you were done with 4 infusions, that is 1 cycle completed, they were given at least 5 weeks of follow-up to assess how they were doing. And if there was improvement noticed, then they could do another cycle after 4 weeks or so, but no sooner than 8 weeks from initiation of the previous cycle. So over a course of 26 weeks, you can only undergo maximum of 3 cycles. So this is just a brief overview of what happened. So ultimately, we had 216 patients were screened, but enrolled were a total of 167. Out of these, in 1:1 ratio, they were assigned to efgartigimod or to placebo. And this was an intention to treat study. So as you can see, this is ultimately 79 completed treatment and 73 did not complete treatment. However, they were included in the results, even those who discontinued due to various reasons. Now, how did we assess the efficacy, whether it really worked or not? So the assessments of efficacy were done every 8 weeks after initiation of each cycle. So the first thing was the Myasthenia Gravis Activities of Daily Living scale. And then we have the quantitative Myasthenia Gravis score and Myasthenia Gravis composite score, and 15-item revised version of the Myasthenia Gravis quality of life questionnaire, and finally the EQ5D quality of life scale. So how do we decide if something was efficacious? We mainly looked at the Myasthenia Gravis Activities of Daily Living scale, and if they found that from the baseline there was a reduction of 2 or more points, it was considered effective. At the same time, we also checked the autoantibody levels and normal immunoglobulin levels at the same time. So the autoantibodies we were looking for were the anti-acetylcholine receptor antibodies and the MuSK antibody. So what were the outcomes? So we had primary endpoints and secondary endpoints. The primary endpoint was the proportion of acetylcholine receptor antibody positive patients. So it was only in these positive patients who were Myasthenia Gravis Activity of Daily Living responders. What that means is that after the first cycle, that means in the first 4 to 8 weeks, if their score had improved by 2 points or more, that was considered the primary endpoint. Whereas the secondary endpoint assessed all the other scales, such as the QMG, the quality of life, and also in antibody negative patients as well. Okay. So moving on to the baseline demographics, as I mentioned before, 216 were screened and there were a total of 167. Now, out of those, what is important to note is that 77% were antibody positive and only 38% were antibody negative. So it wasn't completely equal, the positive and negative. And only 4% were MuSK antibody positive. However, this did represent the generalized Myasthenia Gravis population. Now, this is the baseline demographics, and I want to focus on 3 main things. They were equally matched across the placebo and the treatment group. However, if you notice, those who had undergone previous thymectomy, the efgartigimod people had, those who received efgartigimod had undergone, 70% of them had undergone previous thymectomy. And And as I mentioned before, the acetylcholine receptor antibody positive patients constituted around 77% of the overall population. And finally, when we look at the total myasthenia gravis activity of daily living score, that is the baseline score, it was already quite high, meaning it was 9 or 8. Despite these people receiving either steroid or immunosuppressants or something or other, it was still high. So coming down to the results. So in the results, you can have a look here, is that we're looking at all the scales or the MG-ADL score. I'm going to begin with this one over here first. So the one in blue is the Efgartimod group, and the placebo group is represented in red. So over here, over around 8 weeks, you can see how the points have dropped, meaning the lower the point, the better the improvement. And for us, -2 or more is considered efficacious. So as you can see in this first graph over here, that over the first few weeks, the scores consistently dropped, indicating it was effective in treatment and improving their quality of life. And the maximum effect was reached around 4 weeks. And this was consistent across the other scores as well, except for the last one, that is Myasthenia Gravis quality of life score, in which the maximum effect was reached around 5 weeks. Now, this can be summarized in this table over here. As you can see, in cycle 1, that was the primary endpoint, 68% versus only 30% responded. And this was significant because the p-value is less than 0.001 and the odds ratio were 4.95. Similarly, for quantitative myasthenia gravis responder cycles, 63% responded versus 14% in the placebo group. And so on and so forth. You can have a look at this. Most of these values were significant. And what is important is that we wanted to check when would the effect start waning? When can we see that, the symptoms are worsening again? For people who had taken Efgartimod, we noticed that after a period of 35 days, the effect wore off and they weren't feeling that well. Whereas in the placebo group, in only 8 days, they reported that, yeah, we're not feeling well, there was no effect, or we are back to baseline. Now, this is something which represents the minimum improvement. Minimum improvement is basically how much, for example, 77% of the population, the treatment group people saw a minimal improvement of at least 2 points in the score. And so this, you can see that versus in 48% in the placebo group, and so on and so forth. You can see the blue represents the treatment group and the red represents the placebo group. And this is consistent with the quantitative myasthenia gravis score as well. And one more thing to notice is that for some people, it was minimum of 2 score points that improved, or for some people, it went up to even 9 and 10. So the score improved by 9 or 10 points, which is considered incredible. So summary of the results, I think I've summarized it all over by the tables and the charts. You could have seen that, so I'm going to just go over this very quickly. Yeah, okay. So coming down to the adverse effects. So the adverse effects, what was noticed was that both of them were head-to-head, more or less, but the most common adverse effect were just headaches, but it's not very significant, as the placebo group also had around 28% of them, and 29% of them also had headaches as well. And yeah, otherwise no serious adverse event occurred. Those adverse events which did occur they were unrelated, like myocardial ischemia. Some got pregnant, so they were discontinued from the group, and so on. So the pros and cons is that it is clearly effective. It has a very early onset of action, as can be noted before from the charts, that improvement started within 2 weeks of starting treatment. That is 2 weeks of the first shot. And it was well tolerated. The side effects, the most common one were headaches, and there were no serious adverse events as such. And it is a very selective action. So it is a targeted therapy. And what it does is that although it decreases the levels of IgG, the body is still able to produce IgG. That means it can still mount an immune response. However, the cons would be is that it is an antibody at the end of the day, so it could be pretty expensive. Now, what are the limitations of the study itself? The limitations of the study is that the length of follow-up limited was only over 26 weeks. However, they did follow this up with ADAPT plus studies and so on to monitor its effects. And another thing is that there weren't enough antibody negative patients that were recruited. So amongst that population, if you consider, the power was pretty low, because 77% of the population were antibody positive. So what are the potential is that this therapy is not just it hasn't just been approved for myasthenia gravis. We're also looking at applying it for immune thrombocytopenic purpura, because it also targets the IgG, specifically IgG1, and bullous pemphigoid, chronic inflammatory demyelinating polyradiculoneuropathy, and also autoimmune myositis. These are my references, and I'm done with the presentation. If you have any questions, please feel free to ask. Thank you.